Thank you very much, Michael, and thank you very much for the presentation. We still have a couple of minutes for questions, so I think we received some questions. I'll allow Michael and Matthias from Kucher and Partner just a minute of time to go through the questions. And the most important ones, or let's say the ones related to report, can still be answered by Michael. I will be as well that the presentation and also the recordings of the webinar you can download them from our website, probably this afternoon or early next week. So now I'll leave the floor to Michael to see if he is able to answer some of the questions that were responded. Also the other questions which we will not be able to answer now, we will try to answer them in writing.
Okay, I'd open just the questions and answers board. Maybe we can look on question number 2. Did your research explore how payers expect originators to react to biosimilar competition in terms of pricing and discounts? We've explored it to the extent that in some countries there are rules. So, for example, or in many countries actually, that is at least at launch handled by the PNR system as such. So in France, for hospital products on a certain exclusion list, there's a requirement that both the originator and the biosimilar reduce their prices by 10%, and then the rest is decided on a hospital level. In countries such as Italy and Spain, there are clear expectations of what has to be expected in terms of biosimilar discount. In Spain, then the biosimilar price or offer is simply taken as a fixed reference price, COOP price, and the originator has to go down. So that's one part in markets where there are pretty straightforward rules how to act in terms of originator prices. That's mandatory. In other markets where these rules do not exist, we didn't discuss that in detail, but what we know from when talking to payers, they leave that up to the originator more or less. So in markets where there are no instruments in place, kind of enforcing lower originator prices as well, typically the payers leave it up to the competitive dynamics. I mean, the originators, as you know, they sometimes react, sometimes they don't react. That depends a little bit on the market situation as such, the biosimilar share, the instruments that are used. So therefore, in countries where there are no clear rules, it's typically up to the originators. Payers will not interfere here. Then whether there's a source where we can see which biosimilars are in the pipeline, we don't have that here. I'm pretty sure there is material, maybe also Martin or Peter from MSE may have such sources. Then there was a long question, I just read through it. The silo effect of budget in hospitals. When looking on gain sharing, that's actually really, I wouldn't say a problem, but that's an issue, and I assume the person who asked for that refers to a situation where, for example, a physician should prescribe biosimilars, but the savings then go into, let's say, the overall hospital budget, and he does not see a benefit. That was seen as an issue because, as you know, depending on the country, there's a hospital budget, there's a drug budget, there's whatever budget, and that's really an issue. And therefore, if you do gain sharing, and there was an example, I think, in the UK, where that was handled pretty well, the effect of the gain sharing, so the savings, were directly invested in the department of the physician. So they had then an additional nurse who could help them in their daily work. And so if you design these gain sharing elements, that's exactly a good point. You have to understand first whom you incentivize, and secondly who benefits from the savings in the end and from the gain sharing, because we totally agree, if it goes up in a global hospital budget, that's not very effective. But the good thing about these gain sharing agreements is that you can tailor them to very individual situation, and in Germany there's a contract in place which is very tailored to a certain indication and so on, so we can account for this silo effect. Then, do payers recognize the risk of supply disruption award exclusive single supplier tender contracts. The answer is yes, no. Of course, they know the effects, but they do not always care about it. That's maybe how I would put it. That is, I think, a problem because on one hand, it's understandable from the payer's perspective that they think that way, because they, as mentioned, have a very short-term focus, a focus on budget savings. For the manufacturers, that's more kind of a long-term thing. If you have a single supplier contract, we have 5 manufacturers, only one wins it. If all markets would work like that, 4 manufacturers can be sure not to make any volume. So therefore, that's something you really have to explain payers in detail, that there's a long-term and a short-term component in that, because only then I think they can be convinced that these single supplier contracts may not be optimal. Then there was another question about what is the best gain sharing approach. I mean, I already talked about that in a second. The key thing here is that the person who prescribes really sees the benefit, goes back to the silo discussion. Then I just went to the very last question: is physicians' choice of biosimilars important for payers? Thinking of uptake of biosimilars and thus realizing cost savings. That depends a little bit. I'm not sure to what extent choice of biosimilars means, whether that is meant between different biosimilars or biosimilar versus originator. If you look into the separate markets, that is handled differently. So in Germany, for example, there are policies which, for example, have quotas for prescribing, and physicians are also provided with information with regards to the price of the different biosimilars. So they can never tell the real prices because that's confidential, but you can provide in an intelligent way a list of prices, biosimilars and originators, by sorting them or whatever. So that to some extent also the payers make clear to the physicians what biosimilar to choose and what biosimilar to prescribe. The key point here, of course, is especially in Germany, freedom to prescribe is a very high element in the healthcare system. So, and in other countries as well. So payers will never force physicians to prescribe maybe one specific biosimilar. Also, often the single lot tenders are strong recommendations. Physicians can always make a case to prescribe another drug. That is the footnote here. But typically, payers indicate to physicians what biosimilar prescription may, let's say, may make most sense, and that can be done in different ways. For example, by providing them with a price overview. That's the last. I was just scrolling down to the last question, and the other ones are very to some extent. I'm just reading through the list. 1 second, please. Then there was a question about, can we explain a little bit more deeply regional differentiation in procurement? When looking on markets such as Italy or Spain, where you have regions, the different regions handle procurement sometimes differently, and mainly because they often tender, and then the regional differentiation is more or less how the different regions handle tendering. Main difference, or the key decision point, is often how many lots do you have in a tender. So do you only have 1 lot? Do you have 2 lots for biosimilars originator? Do you have, in the case, do you have for naive patients? Do you have a lot for experienced patients? That goes into the switching discussion then, and that is the main differentiation on a regional level, I would say. There are different, that's more or less kind of different regional policies. That is all on top of national policies. That's one clear point to say. So for regional differentiation in many countries, there's often a national pricing market access policy in a first step, which kind of disadvantages biosimilars 2 times. First, they have to take a price cut on a national level, and with this lower price, you then have to go to regions and start negotiating prices there. But again, the main differentiation between regions is here how they handle the purchasing process and the tendering and how many lots are set up and to what extent everything is put into one pot, and other regions differentiate more between originate and biosimilar. That's the main difference, I would say. Good. I think, Martin, I'm not sure. I think the other question was a little bit similar to the other one. Is there anything else which is of interest and which we did not have addressed in this Q&A session?
Well, thank you, Michael. Thank you very much for taking the time to reply to some of the questions from the Q&A. I think since we are past 11, I think we will close the webinar now. As I mentioned, the presentation and the recordings can be able to be found on our website. We will also, in writing, put something down on the questions that were asked on the Q&A, the ones that we posed now. So that can also be found afterwards on the website. So I think that makes it easy. And if there are any other questions from the participants, they can be sent to Peter Deals, whose email address is now on the screen. So thank you very much, Michael, and thank you everybody for participating to the webinar. Feel free to reach out to us if you have any other questions. And otherwise, have a nice day and a nice weekend.